Hi, I'm Dr. Susan O'Brien, and I am a professor of medicine at the Chao Family Comprehensive Cancer Center at the University of California at Irvine. And I'm here today to talk to you about some really exciting results that we got at the European Hematology Association meeting just a few months ago on the fixed duration combination of ibrutinib and venetoclax for CLL, the Captivate study. As you all know, this is an oral small molecule combination, so it's very exciting because there are no infusions. The way that we do it is we start the patients on ibrutinib first, the BTK inhibitor, and generally give that for about 3 months, and then start the venetoclax ramp up. And the reason ibrutinib is given first is to minimize the risk for tumor lysis once you start the venetoclax, and it's quite effective at doing that. Then we start the venetoclax ramp up, and then the combination is given for 12 cycles, so essentially 1 year. And at this meeting in Europe, we had 7 years of follow-up. The way the study was originally designed, there were 2 cohorts. There was one cohort that was just fixed duration. In other words, they got the 3-month lead-in, the ramp up, and then 12 cycles of ibrutinib and venetoclax. And then there was a cohort where there was MRD guided therapy after the 12 cycles. And the patients could either be randomized to continue ibrutinib or to be assigned to placebo. And that cohort, which was previously analyzed, did not show a benefit for continuing ibrutinib. So the placebo arm, since they got no further therapy, were also included with the fixed duration arm for the analysis. And the about 202 patients completed therapy. The fixed duration cohort was 159, and the MRD placebo cohort was 43. And they had some high-risk features, including most of them being unmutated. P53 aberration was in 14%, and complex karyotype was in 17%. What we saw is that at this long-term follow-up, we still didn't have a median progression-free survival. So now it's 7 years of follow-up. And remember, the therapy is only 1 year, and we still don't have a median progression-free survival. I will say one caveat, although some of the patients that I already mentioned were high risk, the population was young. So everybody in this trial was less than age 70. Why would that have a difference or make a difference for the response or the progression-free survival? Just because the younger patients might be better able to tolerate the combo and not stop for adverse events, particularly cardiac adverse events, which might be more common in older patients. But what we saw is that the MRD status at the end of therapy was highly predictive for PFS, as you might expect. With patients who become MRD undetectable, and that's using the standard cut point of 10 to the 4th. Those patients had very, very prolonged remissions, and most of them still had not relapsed. And don't forget that the time at which patients relapse is not necessarily the time at which they need to be retreated. Of course, right? If you're watching patients closely, especially if they've been on a clinical trial, and the first sign of recurrence is, let's say the lymphocyte count is 10,000, we don't have to treat those patients. So always remember that the time to next treatment is often substantially longer than the PFS itself. In addition, the patients could be retreated when they progressed. They could either receive single agent ibrutinib, or if they had been in remission more than 2 years, they could receive ibrutinib and venetoclax combo again. The first important point is at the time that progressive disease was identified, no resistance-associated mutations were seen. And that's what we at least hope for, right? Because you're not continuing the patients on either drug. And so you would hope that you're not driving a potentially resistant clone. And sure enough, no BTK mutations were seen, and no known resistance-associated mutations were seen in BCL2. We did have some data on retreatment. 25 patients were retreated with ibrutinib, and the response rate was over 90%. and a smaller cohort, or 11 patients, were retreated with the combo of ibrutinib venetoclax, and the response rate in those patients was 100%. So not a huge database, but a database suggesting that, yes, we can retreat patients with either drug or both when we use finite therapy that's only given for 1 year. So the combination of ibrutinib and venetoclax is all oral, once daily, totally chemo-free, fixed duration regimen for first-line treatment of CLL or SLL. We now have long-term data showing that the PFS and the overall survival is very durable, and we don't have a median PFS or overall survival. The outcomes are definitely dependent on MRD undetectability, with those patients doing particularly well. And we know that we can retreat these patients with either agent or both and still have really great response rates. We don't have much data on the second remission PFS because that data is just so recent, since our initial remissions are so durable. But with further follow-up, we'll be able to catch that data. And the ERIC is actually doing an analysis to continue follow-up on these patients to see what happens after their retreatment. So we look forward to that data in the future, but it's great to have all oral, well-tolerated, very effective therapy for CLL.